want to, please, can you let me know if I'm audible enough and if you can see my screen? Where I start?
Yes, we can see your screen.
Okay, good morning, everyone. My name is Frances. I work with the Kunle Hassan Eye Foundation Academy, and I welcome you all again to yet another edition of our Retina series, anchored by the Kunle Hassan Eye Foundation Academy. I'm going to go through the welcome and introduction, which is what I'm doing right now. And then we'll take our presentation from the speaker. We'll have an interactive Q&A session and then the closing remarks. So this program is going to run from 5 to 9 a.m. I'll give a brief overview of the Kunle Hassan Eye Foundation Academy. It is a part of the Eye Foundation Eye Care System, and Eye Foundation itself was established in 1993 with a vision to eliminate avoidable blindness. The Eye Foundation Community Hospital was established in 2006, and the Kunle Hassan Eye Foundation Academy, which was formerly known as the Deseret Community Vision Institute, which oversees training for ophthalmology residents, fellows, middle-level ophthalmic practitioners, optometrists, and ophthalmic nurses. The Deseret Community Vision Institute was upgraded to what we now call the Kunle Hassan Eye Foundation Academy. I'll go quickly to the profile of our speaker today. Our speaker today is Professor Tunji Oluleye. He is a vitreoretinal specialist and the head of ophthalmology department of the University College Hospital, Ibadan. He hails from Obo, Ayegu, Kwara State, born into the family of Chief Samuel Oluleye and Madam Dorcas Oluleye in October 1966. He bagged his first school leaving certificate from the Seventh-day Adventist School in Kwara State in 1978. He attended the Government High School in Ilorin and OC Central Secondary School, where he obtained his West African School certificate with 5 distinctions and was admitted to study medicine in the University of Ilorin. He graduated in 1991, and after his housemanship, he proceeded for the National Youth Service. He started as a family physician in University College Hospital in Ibadan in 1995, and through the encouragement from Dr. Kale Jaye and Professor Oshun, he was admitted into the ophthalmology residency program. He completed his residency fellowship in 2001 for both the national and West African colleges. With encouragement from Professor Bayeroju, he proceeded to Eye Foundation Hospital in Lagos for his first exposure in retina subspecialty. He was appointed as a lecturer in Department of Ophthalmology in College of Medicine, University of Ibadan in 2004. In 2006, he secured a training grant from the MacArthur Foundation and the International Council of Ophthalmology for a medical retinal fellowship at the L.V. Prasad Institute, India, following which he got his fellowship from the Arabic Eye Hospital and the Institute of Community Ophthalmology, courtesy of the Carl Zeiss Project, an international agency for the prevention of blindness, in 2007. Came back to set up the retina unit of the Department of Ophthalmology in the University of Ibadan College Hospital and has since trained many residents and fellows. He is a professor and now the serving head of ophthalmology department. He has numerous publications on the disease of retina in local and international peer-reviewed journals. He has a book. He has written a book, and one of the professors, Professor Oluri, gave a review on the book. The book starts by giving us an overview of the symptoms, etiology, and pathophysiology of retinal detachment. It gives us the guidelines, and guidelines are made available to help determine the probable position of retinal tears as determined by the type of retinal detachment, which is reviewed on fundoscopy. In this book, emphasis is placed on repeated charting of findings and repeated examination. The appropriate type of surgery for each type of detachment is suggested, and the material for scleral buckling is introduced. The book is surely a welcome addition to our understanding and practice of retinal detachment surgery when diligently followed. So that's a book review on the book written by Professor Oleye, which was given by Professor Oyin. Today, our speaker will be teaching us on the topic on pearls and pitfalls in scleral buckling procedure for retinal detachment. So Professor Oluleye, I welcome you to take the floor. Thank you, sir.
Thank you very much. Let me share my screen. I hope you can see my screen.
Yes, sir.
All right.
Yes. Yes.
All right. Thank you very much. First of all, I want to thank the Kunle Hassan Foundation for giving me this platform. I'm always happy to teach and to share knowledge. I really appreciate him, especially as I appreciate Chief Kunle Hassan for also giving me the opportunity to have my first exposure in retina practice. I will never forget. And because this initial exposure really helped me during my fellowship, I thank him very much. I also want to thank my elders, my teachers, that without which I would not be here today to speak on this important topic. First, I want to appreciate Professor Bairoju for actually being the one to initiate me, to actually encourage me to go for retina. I don't know, at that point, I was not too sure about where to go, but she said, you should be a retina doctor. And that's exactly what I followed. And it was instrumental to my going to Eye Foundation Hospital at that time. I want to also thank Professor Ashaye, who was my head of department at the time I was doing my training. She was the one that insisted that retina must be developed. We need to develop retina. And with the support of my former CMD, Professor Ilesami, they made it possible. I also thank my senior colleague, Professor Ajayi Oba, who was the first person to actually make retina interesting while in the department. I thank him also. I also thank my trainers at LV Prasad, Dr. Nazimu Uzain. He was the first person that actually made it very simple to me. And then for my full fellowship at Lions Arabian Institute of Community Ophthalmology, Dr. Ramasami Kim was like a father to me. So I want to thank them very well. And also members of the Vitreoretina Society of Nigeria, under the able leadership of my chairman, Professor Fieba, and the executives, and all other notable members, Emeritus Chair, Professor Nwosu, Dr. Denilo. I thank you all for your support. And my colleagues in Retina, and even in ophthalmology in Nigeria and Africa. I will not forget my African Retina Society. I thank you all for this opportunity. So this morning we are looking at pairs and pitfalls, how to do retina detachment surgery, how to do it properly, looking out for mistakes and what to do and how to do it appropriately. Now, scleral buckling surgery was first described in 1949 by Custodis. And since then, so many things have changed because in those era, there are a lot of trial and error. Okay, was popularized by Charles Chapins in the United States and of course in Nigeria for indefatigability of Professor Lurin, Professor Abiose, Dr. Hassan in Nigeria, scleral buckle became what can be done in Nigeria. Because I remember in those days, if you have retinal detachment, you must travel abroad. But because of these pioneers in Nigeria, he said, no, it's something that can be done here in Nigeria. I want to thank them for this. So the aim of scleral buckle surgery is to reduce vitreoretinal traction because we know the vitreous constantly attached to the retina most times and tends to pull the retina when PVD is about to take place. And this pull may lead to retinal tear. So the aim of the surgery itself is to reduce this traction, create chorioretinal adhesion when there is a tear, and prevent further detachment. Scleral buckle support vitreous base and prevent new breaks, and there is a lower incidence of cataract and scleral buckle compared to other modalities of treatment. Now, this is the so-called rhegmatogenous retinal detachment. When we have a tear in the retina, fluid can easily go into the retina and detach the retina. And it's a devastating condition to people presenting with sudden loss of vision. So in the age of vitrectomy, we know that scleral buckle is reducing. But in our environment, we should not let it die. Because of vitrectomy, we have a lot of indications for scleral buckle surgery in the era of vitrectomy that we must take note of. And there are situations we have to avoid scleral buckle surgery. And scleral buckle techniques must be done to have a good outcome. Now, why is scleral buckle surgery reducing? Because there's small gauge vitrectomy now You can see everything, improve viewing and lighting. There's industry support and the economic aspect too. And now scleral buckle tends to be reducing. But however, we all know that there are indications for vitrectomy that must be followed. So therefore, there are also indications for buccal surgery that must be followed. So indication for scleral buccal surgery, let's look at those broad indications. This list is not exhaustive. We know in young patients with no posterior vitreous detachment, scleral buccal should be considered. Retina dialysis, no PVD, and there is anterior tear, we must consider scleral buccal. Very anterior and peripheral breaks, scleral buccal tend to do well. Inferior retina detachment associated with lattice and holes, we know retina scleral buccal should be the choice at that point. High myopia with RD. So fresh RDs, young individual, no PVD, peripheral breaks, I think we should consider scleral buccal surgery. Of course, in our environment, we tend to see a lot of long-standing retinal detachment with PVR. Of course, vitrectomy will be the choice for that. Now, essential steps for a successful scleral buckling surgery. The first one is adequate pre-op evaluation. We must be sure that scleral buckle will be of benefit to this patient before we offer them. So that pre-op evaluation is the most important step. Examine the patient carefully to choose which procedure is best suited for this patient. And as you can see, we'll discuss that in full when we are discussing the principle of the surgery. Number two is appropriate surgery. Appropriate surgery. What's buccal material to use? Where to put the buccal? Okay, what orientation should the buccal be? Very important. Then number three, which I consider the most important, is the post-operative management. Good post-op management, because if the post-operative management is very bad, it may mess up a very good surgery. So good post-op management is there. So these three essential steps must be borne in mind when we are considering scleral buckle surgery. So what are those principles of scleral buckling surgery that must be borne in mind? The first one, I usually tell my residents, is to memorize this and put it, in fact, write it on the sheet of paper and put it on your wall, because this is a very common exam question. Principles of scleral buckle surgery or principle of retinal detachment surgery. The first one is to find all retinal breaks, because if you don't find the break, you may not be able to treat the retinal detachment. Okay, so find out the break. How do we do that? Binocular indirect ophthalmoscopy in a dilated pupil, scleral indentation, and you must base your findings on Linkoff's rule. So you examine in detail. This is not the time to say, I want to quickly examine for 5 minutes and go for break. No, it's better you go for your lunch, come back, sit down, and do the proper examination. And as you are doing that, you are drawing it. We usually document. Documentation is an art and must be followed. Don't wait until you have finished drawing or finished examining the patient before you now say, I want to put out the drawing. And this is also what we mark in the exam. As we ask you to do indirect ophthalmoscopy, we want you to put down what you have examined. So as you are examining, you are documenting. Number two, once you have found the break, the next principle is to close that break or seal it, seal the breaks. And commonly we use cryotherapy in scleral buckle. Again, you may augment with laser after the surgery or even on the table if you feel the retina is flat. But if the retina is not flat, laser may not work. So cryotherapy is used most times. Then number three, this is controversial. You may or may not drain the fluid. But in our environment where we see a long-standing retinal detachment, we usually advise you drain the subretinal fluid. So, and we have said it here if necessary. You don't have to drain all fluid. Then number four, that's when you now relieve vitreoretinal traction. And that's why we put scleral buckle. Scleral buckle. Now, once you have sealed the break, you have drained the fluid, you need to relieve the traction with scleral buckle. That's why you suture scleral. You suture the buckle on the sclera. We're going to see that as we go along. So techniques, what are those techniques? Now, specific techniques. We mentioned identify the retinal break using the Linkoff's rule. We're going to look at that rule. Close the retinal break. We're going to look at how we do that with cryo. reduce the traction. We're going to see how we are going to put the buckle, encirclement or parallel, especially if there's lattice degeneration, how we are going to apply the buckle. Then segmental, if it's just localized in one area, you don't need to put buckle around the eye. So you can put it in the area of the break. The aim is to treat the breaks and not the retinal detachment with buckle. It can be radial or perpendicular if you have a offshoot tear. Now, instrumentation. Very simple instrument. You have your lead speculum. Rigid speculum is advised, where you can adjust to have a good exposure of the eye. You have your caliper. You have your spring scissors, conjunctival scissors for periotomy. You have your forceps. You have your retractor and the squint hook. And you can see cutting board. You can see the sutures, 4-hole silk. You have 6-0 Prolene non-absorbable suture to anchor the suture. You have the Vicry to close up the conjunctiva. And your xylocaine is there, and Macaine. Usually we do most of these conditions, this surgery under local anesthesia. Okay, but in children, of course, we do a general anesthesia. So what are the other instrumentation that you need? You need your indirect ophthalmoscopy. I usually tell residents you usually need a wireless indirect so that you can move around when you are doing your examination, so that you don't have wires disturbing your movement in theater. Then you have the cryotherapy. This is a simple cryotherapy setup with the carbon dioxide gas, and you have the gauge, you have the probe, and you have the pedal to activate. So once you press the pedal, the probe, you see the tip of it turn to an ice ball, and that you can use. So you don't need any electricity for this. So it's local and can be taken around, can take it to a local environment, your outreaches, and you can perform that. Now, what are those materials that are needed? The silicone rubber, very important. In those days, we used to use rubber, but because it's more expensive now, so we have moved on to sponges. Sponges are cheaper. You can cut them, you can reshape it, you can slice them into two, and that will also help in increasing indentation compared to rubber. So what are those step-by-steps? Now let's look at anesthesia. We've talked about local versus general. In most times, adults will use local anesthesia, peribulbar anesthesia with subtenon anesthesia. Then we add bupivacaine to our xylocaine, and that will prolong the duration of the anesthesia. Conjunctival periotomy, yes. Rectal isolation depends on the extent of buckle. Localization of break with BIO and marker, very important. Subretinal fluid drainage, we've mentioned it if it's necessary. Cryotherapy laser around the breaks, buckle placement. So these are the steps, and the watertight conjunctival closure must be done. So this is the initial step after your anesthesia, your periotomy. If you look at this conjunctival periotomy, you can notice this island of conjunctiva left behind, so that at the end of the day, when you are doing close-up, you can help with a beautiful conjunctival close-up. Then once you have done periotomy, depending on the area of retina, you don't have to do 360. If it's a localized RD in a particular quadrant, limit your periotomy to that quadrant. Or if you think it's a total RD, you may need to manipulate the eye, move the eye in all directions, then you may need to do a 360 periotomy. Then after that, you must make sure you do a blunt dissection of the quadrants so as to be able to save the isolate the muscles. Very important. Then you inspect the sclera to make sure the sclera is not thinned out, because thinned out sclera may be a contraindication to your surgery. So this is how you isolate your muscle. You can use a fenestrated squint hook with your 4-hole silk, okay, and you pass it so as not to injure the muscles. As you can see, it's very easy to do. This is squint hook. Try to isolate the muscle. You can use cotton swab to make sure you remove tenon's capsule. Then you can use a reverse. You can reverse if you don't have this fenestrated squint hook. You can use the needle, that is the 4-hole silk needle, in a reverse manner so as not to injure the sclera or the muscles, and you isolate the muscle, as you can see, depending on how many muscles you want to isolate. So these are bridle sutures that must be done. This will help you to move the eye when you are looking inside the eye. Then the next step is to localize the break. Of course, you will have done this pre-operatively by beautiful drawing, like I mentioned earlier. So on the table, in order to make sure you are not missing out breaks, you still do your indirect ophthalmoscopy. You can see the wireless indirect is better here, no wires anywhere to contaminate your field during surgery. So you do that, you examine in detail. Now, patient is under anesthesia, patient is more cooperative. Then once you isolate or you are able to identify the break, you can mark the sclera. That's where you can see the sclera marker here is applied on the sclera to mark the break. And once you have done that, you check all quadrants to make sure there are no other breaks. Make sure the examination is complete, then you proceed. Now, you can use your link-off rule to identify the break, where the break is, in case you are not able to see it. Most likely in the temporal retinal detachment like this, break is usually towards the higher border between the 1 and 1.5 clock hours. As you can see here, this is first one of the rules of link-off. The second one, if you have a superior retinal detachment, you can see the break is localized within this triangle here with the base between the 1 clock hour on either side of the break, as you can see here. Then if it's inferior retinal detachment, you can see if you have equal borders, then the break is likely to be at 6 o'clock. But if one side is higher than the other, then that will determine the localization of the break, as you can see here. You can see the temporal side is much higher compared to the nasal side. So the break is a bit towards the temporal side. Unlike the one down here, where you see inferior RD and you can see the higher border is obvious here on the temporal side, the break is within 1.5 clock hours to the higher border. Now, if you have a total retinal detachment with inferior bullous presentation, note that the break will be superior because the fluid continues to go in, and the fluid will continue, and that's why you have this bullous nature. So total retinal detachment looks at 12 o'clock. Most times you find the break. Now, drainage of subretinal fluid, we've said if it's necessary. I usually consider drainage around the horizontal meridian, above the medial rectus or lateral rectus, or below medial or lateral. If the fluid is there, then you can drain. Never drain directly on the horizontal meridian where the ciliary vessels are. Never drain along the vertical meridians because of the ciliary artery and vessels. So don't drain in the mid quadrant because of vortex vein. So these are the areas that you should think of. Okay, like I said earlier, if it's necessary, that's when you drain. Now, cryotherapy, because there are situations you need to drain before you apply cryo. If there's highly bullous retinal detachment, you drain, you can inject air into the eye to flatten the retina. Then you can see the break well opposed to the RP. Then you can apply your cryotherapy. As you can see here again, indirect ophthalmoscopy under direct visualization is the key. No wires around, so wireless. Then you can see the doctor is applying the cryotherapy around the break. Never put it in the break itself so as not to liberate pigments, and that may lead to proliferative vitreoretinopathy. So you put overlapping cryotherapies around it, as you can see in this picture, to seal it. Okay, and this is how to properly apply your cryotherapy. Make sure the tip of the cryotherapy is right on the break, not lying across it. Don't put the shaft because you may injure some other tissues around. So make sure it's the tip that is applied. Now, the next step, this is the rate limiting step, how to apply the sutures and to make sure you cover the break appropriately. Now, usually we use a spatulated needle. Okay, as you can see, spatulated is used, but in our environment, this spatulated needle may not be readily available. It's very expensive. So you can use a round body Prolene 6O. This spatulated usually comes with Dacron sutures. Okay, but like I said, may not be readily available. So we use Prolene round body. And what you do, you mark, now you have marked the break, as you can see in this picture. Okay, if this is the brake, your suturing behind the brake must be about 3 millimeters, as you can see. So this suture is passed through the substance of the sclera, not through and through suturing. It must pass through the sclera. Don't perforate the eye. So that's why spatulated needle is ideal. Okay, so as you can see in the picture here, so you measure 3 millimeters behind, as you can see with this blue, light blue arrow. So that means your suturing must come from below. This is the ora serrata here. That's the where the muscles are attached. So, like I said earlier, you mark your brake, put the suture, anchor suture 3 mm behind, and most time you must cover 2 millimeters, okay, anteriorly. So the suture will come like this, and make sure you take the ora serrata with it. So that when you put your buckle, the buckle will lie over the brake. Remember, it's better to cover more the posterior part of the brake than the anterior. So very important. So once, as you can see in the final picture here, the suture has been passed, and you can see this mattress suture is not a true and true suture. Remember that. So at the end of the day, when you put your buckle, this is a segmental buckle. You can see it pass under the recti muscle here, and you can see this at least 2 mattress sutures should be put per quadrant, as you can see here, and it's overlying the brake, and you can see that that is the orientation. That is what you find. And when you look inside at the end of your procedure, you must ensure that the buckle is covering the brake as shown. The posterior part of the brake must be well covered. Of course, you must have applied your cryotherapy before you put the buckle. So as you can see here. Now, these are other configuration of scleral buckles that are done. You can see different, depending on the number of brakes, the orientation, the alignment, where they are. Now, radial buckles is advised for horseshoe tail like this to prevent fish mounting. That is, prevent the reopening of the brake after you have applied the buckle. So you can see here, some may be augmented with a circumferential tire. But most times, if you do your buckle in this manner, you may not need to put a circumferential tire. Okay. Now, after that, you examine again. So always examine and make sure the buckle has covered the brake completely before you continue. And when you do your conjunctival closure, you must make sure you don't hood on the cornea. Avoid hooding, because that will delay wound closure. So you must make sure you trim the edges of the conjunctiva and the tenons, and make sure your cornea is well exposed, and this will aid healing properly. Very important. So what are your notes that you must make? Scleral buckle notes. This is a typical example. You put the name of the patient, the hospital number, the surgery, the surgeon, the assistant, anesthesia, the date, and this drawing is very important. The diagram here is very, very important. You put the diagram here, and this green represents the buckle, the suturing are in blue, the brown ones are the recti muscle, and where you drain the fluid, you must indicate. So this is a complete picture that a retina surgeon will understand what you have done in case the surgery will need to be revisited in the future. So very important. So post-operative instruction must be there. Usually we give analgesic and antibiotics. Positioning of the patient is important. If the brake is superior and you put air in the eye, usually you ask the patient to sit up so that the air will tamponade the brake while waiting for the cryotherapy to take effect. You put your signature and the date. So these are scleral buckle surgery scenarios that are put here to help us. If you see, the first one here is a localized retinal detachment with a hole there. You can cryo that place, okay? Put a minimal small buckle there to prevent, you don't need to drain any fluid there. It's a minimal detachment. You cryo the place and you apply the buckle. The second picture here is a much more elaborate detachment, superior brake, okay? Again, you cryo the area again, you put the buckle similarly, okay? you may or you may not drain. Once you close the break, most time the subretinal fluid will resolve. The third picture down is an inferior retinal detachment with a break close to the higher border on the temporal side. Again, you apply cryotherapy. Okay, as you can see the suturing, how the suturing is done. You may or you may not drain. Okay, if you drain, you apply the buckle tightly. Your cryotherapy, the closure of the break is the most important. Once you close the break, the remaining fluid will resolve over some time. Then the other picture here shows a superior retinal detachment with a break at 12 o'clock. Okay, so in this case, you apply your buckle, you cryotherapy, you put a cryotherapy around the break, apply the buckle as shown, you drain the fluid, you put air bubble, and you ask the patient to sit up. As you can see here, the air will float up and stay over that break while allowing cryotherapy to take effect. The next picture down here is a inferiorly bullous RD. Like I told you, if you see this kind of inferiorly bullous RD, think of the break at 12 o'clock. As you can see the break here. So if you apply the cryotherapy over that break, you apply the buckle, you put the sutures, you may drain the fluid and put air. Ask the patient to sit up, the air will try and occlude and take and stay over that break, and the fluid will resolve. Or if you drain the fluid, you may hasten that process. Then the next one down here is total retinal detachment, again with a break at 11 o'clock. In this case, there's some long-standing retinal detachment. So you may need to drain the fluid. You drain it completely. Okay, put cryotherapy, put the buckle, and put air. Okay, and ask the patient to sit up. In this case, you discover that the retina will become flat. Make sure that you do a good cryotherapy. Okay, and the patient is positioned well. Then the last picture down here is another retinal detachment superior. Two breaks now. You can see one at 12 o'clock, one at 2 o'clock. So in these instances, you must identify these two breaks, or else the surgery will fail. So you drain the fluid, you put air, you cryo very well, and you apply this segmental buckle to take care of the two breaks. Very important. The next one, another superior retinal detachment with two breaks far apart. You may use separate buckles in these cases. Drain the fluid, apply separate buckles after your cryotherapy. You can put air bubble to tamponade superiorly, as you can see here. Then the lower picture here is showing an horseshoe tear. Okay, and you can see a localized retinal detachment. In this case, a radial buckle is advised in order to cover the whole tear and prevent fish mouthing. That is reopening of the break after applying the buckle. Then the final one is very unlikely, but we have seen it where there is a bleb in the eye and there is a localized retinal detachment. There is a bleb, localized retinal detachment, and there is an horseshoe tear. As you can see, you drain the fluid, you apply the buckle there, as you can see, and this will also help the patient. So these are buckle for seam breaks. Using Lincoln rule, you know that the break is likely to be around that place. You cannot see it. You drain the fluid, you apply cryotherapy along that area, you put the buckle there, as you can see. Okay, now what are the causes of failure of scleral buckle? Causes of failure. Number one, if you don't apply the buckle appropriately, you can see the buckle this tear is not completely covered. So there's still a gap. So there's a redetachment. So you can see a redetachment here is a source of buckle failure. The next one down here is when you apply the buckle and there's fish mouthing. You can see the break is continuously open here, and you need to insert another radial buckle under the initial circumferential one in order to keep this place closed. And if you have done this on the table, if you have your indirect laser ophthalmoscope, you can apply laser directly around it on the table. Another important thing is if your buckle is too tight, you can see corrugations on the retina. And this, if there's any break in between this corrugation, the break will continuously become open and the retina detachment surgery will fail. So take note of that. You don't need to tighten the buckle too tightly. So causes of failure is summarized: missed breaks, fish mouthing, PVR. When there's a long-standing retinal detachment, PVR is there, buckle may not help. Inadequate cryotherapy can also be a source. Your breaks remain open after surgery. New breaks may form, or you miss the breaks. This will cause detachment. Poor buckle selection. If your buckle is too small, too narrow to cover the break, rather than use a radial, you are using circumferential. Very important. Poor suturing technique. If your suturing is not tight enough or it's too loose, then, or even if it's too tight, it may lead to corrugation. So the appropriate suturing must be done. Okay, contraindication to scleral buckle surgery: poor visualization. When there's cataract, vitreous hemorrhage, you can't see. So usually we advise you go for vitrectomy. Posterior breaks are too posterior, buckle may not reach. Remember we said peripheral breaks are best suited for scleral buckle. Thin sclera, very dangerous in highly myopic patients or patients with systemic collagen diseases. Thin sclera is a contraindication for scleral buckle because you may perforate while putting the suture. Significant vitreous traction in tractional retinal detachment, scleral buckle may not work. Advanced PVR, remember that vitrectomy is advised. So what are the innovations that are taking place now for scleral buckle? Intraocular illumination with chandelier is taking place. Wide field examination with biome, so that you can have a wide field exam as you have in vitrectomy. Then you may be able to localize well and be able to treat and avoid missed breaks. So in summary, because scleral buckle is something that we must embrace in our environment here because of the minimal instrumentation. All we need to do is encourage our patient to present early, and once we see a patient, we must individualize the treatment. Young patients, especially young phakic patients, are good candidates for scleral buckle. Retinal detachment with single peripheral breaks, very important. Inferior retinal detachment with lattice will settle well with scleral buckle, especially in eye myopes. To be good to do scleral buckle. So I want to thank you for this limited opportunity, and thank you for giving me this opportunity. Again, I thank the foundation for asking me to speak briefly on this scleral buckle. I wish all our resident doctors should know how to perform scleral buckle. Thank you very much. This is the book on Amazon. You can go to Amazon to look at our book step by step on scleral buckle surgery, and is now on Kindle. You can also look at it and listen. Thank you very much for the opportunity.
Thank you very much, sir, for this wonderful lecture.
Yes.
Where we really appreciate you for giving us your time.
Yes, thank you very much.
Yes, we'll now go to the Q&A session.
Yes.
If you have any questions from our listeners, any questions, you can raise your hand, or you can ask your question, or you can type your question in the chat box. Questions. Can we take questions, comments, contributions? Okay, there's someone hand is up. Dr. Ome, please unmute your microphone and ask your question.
Okay, thank you very much, sir, for
Yeah.
the lecture. Okay, so I just have a little bit of a question. You mentioned in the contraindications for scleral buckle technique that a patient with a thin sclera, sorry, like in high myopes, is a contraindication. And also in your closing remarks, you also mentioned that high myopes do well with scleral buckle. So I was kind of confused why. Thank you, sir.
Yes. All right. Thank you very much for that. Now, not all eye myopic patients have thin sclera. Like I mentioned earlier, when you are starting the surgery, you have done periotomy, you do inspection of the sclera. Okay, not all of them will have thin sclera. The reason why we don't do scleral buckle for thin sclera is when you need to pass the suture Remember I told you the suture, we have to go through the sclera, not through and through the sclera. So you don't want to perforate the eye, because the moment you perforate the eye, you create new breaks, okay? And that's a big complication. So not all eye myopes will have thin sclera. Well, so that's why eye myopes they are still, because most of them, they will have lattice, they have inferior RDs, and scleral buckle will be much more beneficial to them on the long run, okay? So if you identify thin sclera on the table, then they may not be candidate for scleral buckle. But like I said, not all eye myopes have thin sclera, okay? Thank you.
Thank you very much, sir.
Yeah.
Do we have any questions? Do we have questions or contributions? Okay, I think there's a question in the comment section. Let me just read that out. So the question is from Dr. Harriman. Thank you, Dr. Oluleye. Do you live in the situ, the air? Sorry, I don't know if I'm pronouncing. Maybe that's meant to be. Do you live in the suture, the air that is used to inflate the globe at the end of surgery, or do you replace it with BSS or other compatible solution? Is there any risk of air embolism? I think there are like three questions there. Yes, sir.
Okay, the first one is whether we leave the air bubble in the eye.
Yes, at the end of the surgery, or do you replace it with BSS or other compatible solutions?
Now, what happens is that the moment you do subretinal fluid drainage, there is hypotony, and we don't want hypotony, because hypotony may lead to choroidal detachment. So that's why we usually put air bubble, and especially if the break is superior. Let's say it's at 12 o'clock. The moment you put air bubble there and you put your buckle, it increases the pressure inside the eye and prevent hypotony. So the air eventually, within a few days, will get absorbed. You don't replace the hair, because by putting balanced salt in the eye at times, you may reopen your retinal detachment break, especially if the break is inferior. Fluid may go into the break again and redetach the retina. So it's not in all cases that we put the air. If after putting your cryotherapy, your suturing, and your buckle, the pressure is normalized, you don't need to put air. Or if you feel there is significant hypotony, either because of the amount of fluid that was drained, then you may need to put air. But the good thing about the air is that in a few days it will get absorbed. And again, because the air usually will make sure it's one single bubble, not multiple bubbles. When we put air inside the eye, we make sure it's a single bubble so that it stays together, cohesive. And by the time we position the patient is sitting up, the air is floating to stay over the break. Okay. What's the next question?
The next question is there any risk of air embolism?
Yes, anytime you are putting air into the eye, yes, there's risk. But like I said, we make sure the air is in a single bubble. So we usually don't put fish eggs. You know what we call fish eggs? When they are in multiple bubbles, you don't put inside the eye. So we put a single bubble, and most times it stays together and there's absorption gradually. And within a few days, aqueous humor will replace that space. And most times, the risk is very minimal.
Okay, we have another question from Dr. Victor Ome. And the question says, thank you, sir, for this lecture. When do you choose encycling band?
Okay. Now, unfortunately, now we don't do encirclement anymore, especially in those days where you have PVR. When you have PVR, then you need encirclement. But nowadays, when the patient is presenting with PVR, I just refer them for vitrectomy, or they do vitrectomy. They don't need to do buckle. So we hardly do encirclement anymore. So most times, the aim of Boku is to treat the break, not retina, not the whole retina detachment. So if a patient presents early and the break is localized, even if it's total RD, like all those scenarios I gave, treat the break, drain the fluid, retina will be flat. But if there is PVR, significant PVR, and you know this retina will not settle, I think the patient should go for vitrectomy rather than put encirclement. Okay. Any other?
Yes, we have another question from Dr. Riley at Chudunke. So thank you very much,
Okay.
sir, for this lecture. When can scleral buckle be combined with vitrectomy in a patient? When can
Very good.
scleral
So
buckle be combined with vitrectomy in
we
a patient?
combine. Very good question. Like I mentioned, if there's PVR, and you know that scleral buckle alone will not work, then you need vitrectomy. So patient with long-standing retinal detachment and with significant vitreoretinal traction, and you know vitrectomy alone will not settle the retina, then you can put a belt buckle around the eye to relieve vitreoretinal traction from outside, while you use your vitrectomy to relieve the traction from inside. But this is another controversial area, because some surgeons nowadays said if you can dissect all the vitreoretinal traction from within, you may not need to put an encirclement band again. So there are different school of thought. Some people believe you do the two together. Some believe adequate vitrectomy with dissection of the membrane may not necessarily need you to put a band around there. Okay, thank you.
Thank you, sir. Do we have any more questions as we round up for this session? Any more questions or comments? Any more questions? Dr. Derrilo, do you have any comments or additions?
Yes, I want to thank Professor Lule for a fantastic lecture. I think the Vitretina Society is one of the few societies in the world, I mean the Vitretina Society of Nigeria, that still encourage scleral buckles. We believe that it's very important in our own environment, especially as the need for expensive equipment is quite low. And like Prof has shown us today, with a simple cryo, your indirect ophthalmoscope, and just basic ophthalmic equipment and good thinking, very good thinking as he has put us through. If you have that along with you, most of your buckles will go well. What I also note is that if you reattach a retina with a scleral buckle and the hole and or the tear is safely on the ridge, usually they remain reattached for a long time, for a very long time, except in cases of PVR. That is still a general still a general problem for most of us. I look forward to being able to do a few studies with the effect of scleral buckles on vascular permeability within the globe, because those are some things that people are talking about today. But definitely, as a retina surgeon in Africa, I think you really need to have a good hang of doing a scleral buckle. My Oga has done justice to it. I don't think I really have anything much to add to what he has said, except to say thank you for an excellent lecture. Thank you.
Thank you, sir. My emeritus chair. Thank you.
My Oga, sir. Thank you, sir.
Okay, in the absence of no more questions, we'll bring this session to an end. I'd like to thank our speaker again once more, Professor Luleye, for honoring our invitation to give this fantastic lecture. We usually have the vitreoretinal lecture series organized by the Kunle Hassan Eye Foundation Academy every first Wednesday of every month. So the next lecture is going to come up in the month of May, and we'll be circulating reminders to let everyone knows, specifically on the 3rd of May, we will have our next lecture in the series. You can also go to our YouTube page, the Kunle Hassan Eye Foundation Academy. Follow us. You'll see some of our other series that are not under the Retina, which are under the Founder series. Once again, I thank you all for giving us your time. Thank you very much. Thank you so much.
Thank you.